All right, so I'm Edwin Jackson. I think I've met most of you, but hope everyone's having a good start to the new academic year. This is lecture number 1 in our Focus on lecture series. So before we get started, these slides and this discussion will be worthless to you unless you use what we talk about in your practice. The ultrasound is one of those skills that you have to use over and over and over again for it to be beneficial.
Yeah.
So today we're going to talk about the lower extremity DVT exam and point of care ultrasound. So our objectives, we're going to identify DVT risk factors. We'll talk about POCUS exam indications. And the most important part of this is understanding the relevant lower extremity vascular anatomy. If you don't know the anatomy, you won't be able to understand what you're seeing on ultrasound. So we're going to hit that anatomy pretty hard during this next 35, 40 minutes. I want you all to walk out of here with an understanding of the difference between a 2-point and a 3-point DVT exam. We'll focus on the 5 areas of lower extremity clot formation. I want you to understand what are consistent with positive findings, but then also need to understand what is a false positive and how we can manage those. So the basic indications for this exam: leg swelling, erythema. You can use this for undifferentiated shock, certainly for concern for PE, and then as part of a secondary fever workup as well. The real indication here, though, is if you have some clinical concern that the patient has for DVT, you should try to use this exam. So who's at risk? Pretty much everyone is in the hospital at some risk for DVT, but some risk factors that we should be aware of: mechanical ventilation, anyone who's septic, trauma, liver failure, immobilization, pregnancy is a big one, recent surgery, chronic ESRD, obesity, malignancy, unfortunately COVID-19, and then our general ICU patient as well. So next we're going to talk about the anatomy, and again, this is the most important part. If you walk out of here with nothing today, except understanding the word anatomy, you've succeeded. So we'll start with a question. I'll make you read it. I'll read it to you. An occlusive thrombus is discovered in the superficial femoral vein. Should this patient be started on systemic therapeutic anticoagulation? So we'll skip over our first year colleagues.
Well, they should all know it because I've given this first lecture.
Well, anyone who wants to answer this question. Dr. Twigler, direct you down here now.
There you
Yes.
are.
Yes, okay.
Yeah.
And upward is yes. So you're correct. Prior to 2005, many vascular laboratories would use the term superficial femoral vein in their duplex reports. So this term was a huge problem. If you're looking at a report that says clot in the superficial femoral vein, you may think that this is not part of the deep system, and you will probably withhold anticoagulation. So since that time, the superficial femoral vein has now been termed just the femoral vein. And you'll kind of see how that incorporates as we move along. Okay. So more questions. You're going to be seeing this slide in this lower extremity vascular anatomy probably 20 times during this lecture. So for those of you that feel pretty confident, I'm just going to put the mouse pointer on a vessel, and I want you to yell out what you think it is.
External
Oh, yeah.
This is literally written for you. I'm glad you got that.
Oh, that was a trick.
Okay. So how about this one? What is this? So we have a femoral, we have a deep femoral.
Common femoral.
Common femoral. Perfect. That's a common femoral range. How about this one?
Great.
Very good. Great sound.
Oh,
Perfect.
shaft.
All right.
Forgot about that.
How about this one here?
Deep femoral.
Deep femoral? Okay. Good. That's correct. Here.
Superficial. The vein formerly known as a superficial.
Yes, that's right. Our friend formerly known as the superficial femoral. So this is the femoral vein. And then lastly,
Popliteal.
So, very good. So we want to be able to look at an ultrasound and be able to identify what vessel is. And these are really the five that you're going to look here, with one inclusion here, which is the lateral perforator. So understanding your anatomy makes it easy for you to identify the five areas of clot formation. And these are important because these are areas of either bifurcation, so where a vessel splits from 1 to 2, or areas of compression. So we'll go through these one by one, and we'll look at how they are visualized under ultrasound. So with this slide, we'll go down. The first area that we're concerned about is this common femoral vein. And this vessel is under compression because it's an inguinal ligament. So it's a nice place for clots to form. The second is here. This is our common femoral greater saphenous vein junction. So you'll see a lot of DVTs there as well, again, because it's a bifurcation. Now, keep in mind, the greater saphenous vein is not a deep vein, it's a superficial vein. However, if you see clot at that junction, you typically want to anticoagulate the patient. The next site is the common femoral and lateral perforator bifurcation, which is here. And we'll show you exactly how that looks under ultrasound. Once you see it, you probably have seen this vessel 1,000 times put in femoral lines. And then the next one is that bifurcation from the deep femoral and the femoral vein. And then lastly, our popliteal. All right. So on the right-hand side of the screen, this is an ultrasound of the common femoral vein at that first bifurcation point. So this is how it looks on a negative exam. So you have nice compression there. You can see that common femoral vein. At the 9 o'clock position, you can see a valve kind of hanging out there. So you always want to make sure that you get that view and get that compression. So that's the first area that we're going to look for. The second area is this Saphenous Junction. Let's take a look at how this looks under ultrasound. And right here is the saphenous vein going into the common femoral. How many of you have seen this before while putting in a line or on your own DVT exams? So before you're out of fellowship, you're going to find a clot in this area. Pretty common for them to be there. So you always want to make sure that you visualize that. Next is our lateral perforator. This is also a superficial vein. This drains the blood from the subcutaneous tissue and the thigh into the deep system. So you see a clot at this junction, you should also strongly consider anticoagulation as well. That's how this one looks. Right here, there's your lateral perforator. So next is our femoral vein and deep femoral vein. So if you recall, we're scanning down the common femoral and then bifurcates to the deep, formerly superficial femoral vein. So I want you to focus your attention right here in the common femoral vein. To kind of bounce back on our last slide, this is the lateral perforator here. As this video goes, you'll see this vessel go from 1 to 2. Take a look at how that gets under ultrasound. So there we have our superficial, formerly superficial, excuse me, and now deep femoral vein. This is the area that you always want to investigate as well. And then lastly is our popliteal. So remember that it's just pop on top, so the vein is on top of the artery, pretty easily compressed, and we'll talk about some strategies to get a good view for that vein as we move along. All right, patient positioning. When you're doing this DVT exam, you want to position the patient so that the veins are their maximum defensibility. So you want that vein nice and big, and you want to be able to get into the areas where you need to have your probe so that you can get a good picture. So for the positioning, the patient should be supine, head of bed 30 degrees. And there's actually some good data for how we can make that femoral vein look bigger. Something called the frog leg position. Paper in 2012 from Emergency Medicine in Australia showed that this frog-leg position increases the size of that femoral vein by 2 millimeters, and it actually decreases the depth. So if you're looking to put a CBC in a patient, you should try it in a frog-leg position. In addition, if you're doing your DVT scan, you should also position your patient in this way. So this is actually how that looks. You can see the lateral rotation, and you see the knee flexion there. This is where you're going to scan down on the medial side of the patient's leg in that frog leg position.
So that doesn't change the bend, like if you're putting a line, it wouldn't, you're still pretty,
Yeah, you're still very sharp, so it's probably going to straighten it out for you.
I've never done that.
So we also have another vessel that we need to look at. That's the popliteal. So the positioning of the leg to identify the popliteal vein can vary.
I've never.
If you have a patient that has a larger body habitus, you can run into some significant trouble seeing this vein. I typically start in a frog leg position. I try to do my scan. If I can't get it that way, I'll reduce my pressure. For those of you that did the ultrasound over at Fairbanks, we kind of talked about that light pressure under the popliteal, and you know how easily collapsible that vessel is. If you're having trouble visualizing that, you can do one of three things. The first one is reduce pressure, like we talked about. The second one is assisted knee flexion. So this is an opportunity to engage the nursing staff, the residents, or your attending, and have them hold the patient's knee so you can get right in the popliteal groove and not apply too much pressure. If that doesn't work and you're able to do this, I know many ICU patients, we can't prone them without an active, the president of the hospital. You may want to try that because you'll be able to get the popliteal that way. I put the big stop sign on this because you don't want to hold the patient's knee up with a probe. You will collapse the vein every time and you won't be able to visualize it. So don't do that. Next, let's talk about probe selection. So I have some vascular probes from our different hospitals. The one on the left is the vascular probe at Espinosa. It's gigantic. It's got a very large footprint. It's very difficult to manage. So I don't suggest you use it. You can use a smaller vascular probe that we have at Espinosa as well, but it's on just the ultrasounds that the nurses use. So if you're doing a DVT scan, particularly if you're trying to get that popliteal faucet, I recommend you use a smaller vascular probe. At university, you have this microvascular probe, which is excellent. I wish we had this probe on all of our ultrasounds, but you either want to choose this probe or this probe. So how much pressure should be applied when you're trying to diagnose a DVT? So you want to have enough pressure so that that artery that's next to the vein collapses slightly. So let's take a look at this. You see that will collapse slightly. So once you've done that, that's appropriate pressure, and that's a negative exam for that segment. All right, here's our next question. What is the characteristic echogenicity of a subacute or chronic thrombus? So just yell out the answer here.
D.
D. Yes. Anyone else? C. So whoever said D, why do you think that's the right answer?
Because solid things are more hyperechoic than liquid things.
Okay, so that's a fair point. And whoever said, was it B or C? C, why do you think it's C?
Because usually all you can see is the dark space, and when you compress, you don't get compressibility, so you don't see anything outside of the normal huge numbers.
Okay, that's a fantastic point. We're looking at subacute or chronic thrombus here. So seeing that, you want to change your answer?
Yeah.
So you bring up a great point. And the answer is D. But as Evan said, acute thrombi are anechoic or hypoechoic. And this is because they haven't had time to form that phylum portion, so you often can't see them. This isn't in every plot. Sometimes the acute plots you'll be able to see, sometimes you won't. But the point of this is, if you have lack of compressibility, that is a positive exam. You don't have to visualize the plot in the vessel. If you can't compress it, that's positive. So here's an example. of a subacute DVT in the popliteal vein. Take a look at how that looks. So we can see we're trying to compress it. We see the artery compressing slightly. And we see that vein is not compressed at all. So again, the diagnosis of the DVT is made two ways, either visualizing a clot in the vessel or the vessel not being able to collapse. And again, acute thrombosis often just results in non-compressibility, like Evan said, because there's no fiber yet to form that contingent clot.
What about doctors?
So we'll get to that.
Okay.
So what exam should I choose? Well, before I give you a choice, let me tell you the options. So when you type in your order, bilateral low extremity DVT ultrasound, you're actually getting a vascular lab study called a duplex ultrasound, where they're using V mode, they're using Doppler, they're also using augmentation and color. Okay, so the vascular tech comes to the bedside, they scan sometimes at the area of the external iliac, they go all the way down the leg, the calf veins as well. What we do is either a 2-point or 3-point exam. So we don't use color, we don't use Doppler, and we don't use augmentation for the studies that we do. And you might ask, well, what are we missing here? Is this 2- or 3-point exam as good as a color-coded Doppler exam done by the vascular lab? And in my opinion, the answer to that is no, our exam is not as good. But there is some data that would suggest that using serial Dopplers plus D-dimer is as good as using a full leg DVT. So this study was published in 2008 in JAMA. And what they did, they took 2,400 ED patients who had suspicion of having a lower extremity DVT, and they did a 2-point exam, which we'll go over in detail here on the next couple slides, plus D-dimer versus a whole leg. An important thing to remember about this study is these were serial exams. So the patient came into the emergency department, they got a D-dimer. If the D-dimer was low and their 2-point exam was negative, they let them go. There was nothing else. If the D-dimer was positive and their lower extremity Doppler was negative, they were to come back in 1 week and get rescanned. So the thought was maybe they had some calf DVTs that were coming up into the thigh system versus just a whole leg Doppler. So with serial ultrasound, we can maybe say that that's as good as a full study. So let's take a look at our 2-point exam. So now that you guys know the anatomy, you're going to know that 2-point is actually a misnomer. This is more like 2 area. So on our 2-point exam, we're going to go common femoral. We're going to get that first bifurcation at the greater saphenous. We're going to get that second bifurcation at the lateral perforator. But we're going to stop once the common femoral turns into the femoral and deep femoral. So we're not getting the deep femoral vein and we're not getting the femoral vein. We'll start again at the popliteal vein until we go down to the trifurcation. So the question that comes up in my mind, how many clots are we missing in the deep and femoral vein? So Evan, we're leaning a lot on our emergency medicine colleagues, so we have to tip our hat to you because they actually took a look at this. 2014, Annals of Emergency Medicine, they looked at isolated deep venous thrombosis and implications for the 2-point exam. So what they did, they had 2,400 ED patients, they found 362 DVTs, and they found 23 that were isolated to either the deep femoral or femoral vein. So you're going to miss that on your 2-point exam. And the reason why they only included isolated DVTs is because some patients had a DVT in their common femoral and deep femoral. Some patients had a DVT in their greater saphenous, common femoral, and deep femoral. So they threw those out because you can catch that on their 2-point exam. We just wanted to focus on what will we miss. And from this study, about 6% of acute DVTs are missed on the 2-point exam. So here, those of you that
Like this doesn't add up to 300.
yeah, it doesn't add up because I left out the
Like
non-isolated.
Oh, okay.
Yeah, so Maria with the good eye, you see the numbers don't add up because I didn't put in the non-isolated. So again, for this study, if you had a deep femoral plus a common femoral, I didn't put it up there. So about 6% of the acute DVTs are missed. on the 2-point exam. So for those of you that did the ultrasound with me earlier this year, we taught you the 3-point exam. So let's go through what that looks like. So again, you start with the common femoral, you're going to get that greater saphenous, the lateral perforator, but you're going to go to the deep femoral as far as you can, and the femoral vein as far as you can. For those of you that did that DVT with me, what technique can we use to better visualize the deep femoral and femoral veins? You guys remember? Something like, yeah, exactly. So you're in that frog leg position. You take your hand that you're not scanning with and you lift the leg up so that you can push it closer to your ultrasound. Now, individuals that have, larger body habitus, that deep femoral vein goes away pretty quickly, but you should be able to get that femoral vein at least to the mid, the mid vein portion. Lastly, we still do our popliteal vein, and we scan that all the way down to the trifurcation. So I mentioned trifurcation a couple of times. Does anybody know what I mean when I say trifurcation?
When it goes into the cap, basically.
When it goes into the cap. All right.
All those little compartments that I learned first year, that and then forgot.
So the trifurcation that we're looking for is when the popliteal vein goes into the anterior tibial, posterior tibial, and peroneal vein. These are difficult to see, but you should really try to focus on this and try to do one compression at that site. Once you've done that, your examination is over. So this is how the trifurcation looks under a perfect ultrasound. Those of you that have done this, it looks a little bit different, but you really should try to focus in and get down to the trifurcation. All right, so this is about maybe a minute and 30-second video of a 3-point examination. I want someone to tell me what this sonographer has missed on their 3-point examination that you won't miss. So focus on this, tell me what they've missed, what vessel bifurcation are they not getting that you're going to get. All right, let's take a look at this. All right, you see that they have front leg position. They're scanning down 1 to 2 centimeters and doing compression. There's our compression there. There's our common femoral vein, common femoral artery compressed as well. There's our greater saphenous. There's our deep femoral vein and femoral vein, you can see. So what vascular bifurcation did they miss here?
Lateral perforator.
Yeah, the lateral perforator. So you always want to make sure you get that lateral perforator as you're standing down. Very good.
Is the anatomy pretty consistent, at least in the vessels across some people?
Yeah, it's very consistent. Yeah, very consistent. All right, so now that you guys understand the anatomy, you know the difference between a 2-point and 3-point exam. So you know that you're always going to do a 3-point exam. Let's talk about some false positives. So there's really 5 that I want to go over today. There's one that can have serious implications to how your patient's going to do. So you have the superficial thrombophlebitis, the Baker's cyst, enlarged inguinal lymph nodes, and growing hematoma. So sometimes you'll see the accessory saphenous vein, it'll be thrombosed. This is not a DVT. When you're looking at this, you should be able to identify your common femoral vein here. We don't anticoagulate this, but I think it's worth another ultrasound. Second one is a Baker's cyst. It's going to be in your popliteal fossa. So this one shouldn't confuse you because it's very large. You should never have a popliteal vein as large as a Baker's cyst. And you can also see a start and a finish to the Baker's cyst. There's a kind of synovial fluid that kind of leaks through, and you can see a neck there. But you should also be able to see your normal popliteal vein of length. The next one is a lymph node. Now, the second and third years that I've done a fair amount of VBUS, this is not going to confuse me. These look just like the mediastinal lymph nodes. Again, a trick to this, longitudinal view, a lymph node is going to have a starting point and an ending point. and a vessel wall. Lastly is a growing hematoma. This one can be a problem. This one can be a problem. If the hematoma is big enough, it can actually cause a DVT by compression. So sometimes you're going to have to rotate the leg, do a lot of kind of moving around the patient to try to trace that vascular anatomy. But the hematoma can be a significant problem.
And then what do you do if they have a hematoma and DVT?
So your finger opens, Maria. All right, so next up, there is a 70-year-old male. This is an Eskenazi. Those of you that have been an Eskenazi with me, know how angry I get. This is a 70-year-old male. It's a bad place. But anyway, 70-year-old male
Oh my God.
presents to the ICU under endovascular fluid of an aneurysm. This is performed by interventional neuroradiology. They use right femoral access. He develops pain and insertion on physical exam. You know, the pulsatile mass and bruising below the right femoral ligament. POCUS of the right femoral artery shows the following. So before I show you this, we're primary for these patients. So they come out of their procedure and we take over.
Okay.
We're in charge of discharging them, making sure everything goes well. So we'll probably see one of these. Here is picture. So,
Call surgery.
okay. What is your diagnosis? That's not it. What is your diagnosis?
The pseudoid.
Looks like a so 80 special maybe?
Yeah.
Okay.
There's pulsatile flow.
Someone said something. Anybody else? You literally said the right answer.
Well, pseudoaneurysm. Okay.
Thank you for your. All right, so
Sorry.
this is a pseudoaneurysm. So you'll see these pseudoaneurysms, not infrequently. A lot of times cardiology will do radial first, or will do radial access, less likely to get that there. But in some patients that can't get it, they'll get in a femoral artery. So let's talk about what a pseudoaneurysm is. This is a contained rupture. So this is not part of the vessel wall, what you're seeing here. That's not vessel wall. What's happening is the blood is leaking out of the puncture site, and it's actually dissecting the soft tissue around it, and it gives an appearance of a sac. So the surrounding tissue confines the blood there. There's usually some hematoma formation. And when you get that, that's why you're going to see that saccular area. So that's not part of the vessel. Take a look at this. This is a femoral artery pseudoaneurysm.
Whoa, that's pretty cool.
So when does this happen? Typically after arterial catheterization, sometimes with line insertion. You can also see this if the artery's been grafted during trauma, and less commonly myocardial aneurysms. Sometimes we cause these. So you have a patient who's being anticoagulated, they may be obese, they may be hypertensive, and you put in a femoral arterial line. The biggest risk factor, despite all these other things, is insufficient manual compression. So if you put in a line, your patient has these risk factors, and the line's removed, and only 3 or 4 minutes of compression is held, that can be a problem. So the rule of thumb that I was taught, there's no data that I've seen for this, but this is what I was taught when I was a fellow. So 4 minutes per French size. So if you have an 18 gauge, that's usually the size of our femoral arterial lines, that's a 4 French. So you should have at least 16 minutes of manual compression.
Wow,
Okay, so
never done.
most of the time, the nurses are good about that. They'll hold pressure for 15 minutes, which is reasonable. However, this is the minimum. If you have a normal patient who's not anticoagulated, who's not hypertensive. So if you're getting in that femoral artery, you really want to make sure pressure is being held. We have something called a fin stop. Have you guys seen those before? So if you can't hold pressure or something else is happening, you may want to query about a fin stop. It's just a vascular occlusion device. You can put right on that femoral site and you can pump it up, just like a blood pressure cuff. and it'll give you that requisite pressure. So a couple other things can increase your risk, things that we do, which is puncturing the vessel at a higher low site. So if you take a look over here, sometimes we can get above the inguinal ligament into the external iliac. So besides causing a retroperitoneal bleed, it increases your risk of pseudoaneurysm. Just because the tissue there is has a little bit more give, it's a bit easier for blood to get out. And also if you puncture too low, so if you're in that deep femoral artery or superficial femoral artery, that increases your risk of pseudoaneurysm as well. So you want to always make sure that if you're putting in that femoral arterial line, that you're in the common femoral vein. Okay. Also, we did some axillary arterial lines where I train, and I've seen a few pseudoaneurysms with that. That's a big vessel, and we're usually using the 18 gauge. So again, if you ever do an axillary, you're going to want to hold compression there for at least 15-20 minutes.
And that's after line removal. What if you just stick it and you're like having issues, saying whatever, for whatever reason you have to take the needle out?
Yeah,
Is that as big of an issue?
it is.
Okay.
Yeah, because it's a puncture. Now, if you have a catheter in there, it's going to be easier for that hole to remain. But if the patient's coagulopathic and hypertensive, you definitely want to hold pressure.
Okay.
On the, what do you call that? A fem?
It's called a
Fem
fixed.
stop. Is there like a pressure that you?
So I usually do 80 to 100. On the directions for the fem stop, they'll tell you what to do.
Oh, okay.
I tend to go up a little bit higher for those who are more hypertensive. So, okay.
They cut off
Like, do we have this? Or
We have to ask Espinazi, you have to ask the chargeman for
do
it.
they have like cash?
I mean, what's that?
Yes.
Yeah, so, yeah.
So to diagnose this, typically there's pain and swelling growing after the procedure. You may or may not see that pulsatile mass with a druid. Like I've never seen that one. But if you see that, you want to be cognizant of what's happening. So just to give you an idea of what you're looking for with ultrasound, you're going to take your vascular probe just like you normally would to investigate for a DVT. However, this time you're going to use color Doppler and you'll use pulse wave Doppler as well. So these pseudoaneurysms, they have an anatomy to them. So taking a look at this, this is actually the artery. This was the puncture site. The puncture site then forms a neck where you have very high flow. This is called color aliasing. And that flow during systole goes in to that sac, and during diastole it comes out. So you see that to and fro or union pattern. And again, when you're using your probe, remember our mnemonic there, bark blue away, red towards. So you'll be able to see blood going in and out. When you put your sample volume box over the neck and you use pulse wave Doppler, you'll see something like this. So systole and diastole. During an AV fistula, this flow will be more regular. There won't be up and down. It'll just be more across because you're having blood going from the vein to the artery versus from the artery to a sac that has a little pressure. So again, let's take a look. This is what you want to see. You see that kind of to and fro pattern. Your red and blue and your color aliasing at the neck. So Marie brought up a good point. If you find this, what do? If we caused it, you can't, be as comfortable with this diagnosis. You're like, I hope this is good. But if you ever see one of these, you want to hold pressure. You want to talk to the service that did the procedure. So if it's neuro, you want to talk to them and say, hey, I have this finding. I think they have a pseudoaneurysm. You also want to order a formal study. So they're going to want to see these images in a chart. They're going to want to measure the neck, and you want to measure the aneurysm sac. Because the larger the neck and the larger the sac, the more reason you have to treat it. So you have a couple of things you can do. You can do a thrombin injection. And when I say you, I don't mean us, I mean them. So neuro can do a thrombin injection at the neck. And that can cause immediate stasis of blood flow, and that usually takes care of it. Sometimes if it's bigger, they have to do a balloon occlusion or surgical repair. So kind of the order of operations here, if you find one of these, pressure, formal study, call whoever did it. So if it's cardiology, call them, call neuro, if it's them. And then you may want to call surgery as well. If we did it, order of operations is the same, except IR and surgery.
Where would you, so if the like aneurysmal sac is between you and the vessel, you just put pressure on the aneurysmal sac to get there. Yep. That's not gonna cause it to like.
No.
Okay.
It's gonna cause the patient a fair amount of pain. You're pretty painful.
You said a lot of pain?
Yes, yeah. And that'll be kind of your presenting sign. So the patient will start having significant pain. And then as soon as you touch it, it'll be kind of out of proportion with what someone should have for having a calf. So that should tip you off that they might have one. And that's just because the soft tissues are being dissected in each beat by blood, so it's pretty painful.
And the formal workup, is that an ultrasound or a CT?
Oh, it's a Doppler.
A Doppler.
Doppler ultrasound, yeah. All right. Back to the anatomy review.
Get the arteries off now.
Yeah.
All right.
Leg.
All right.
Right.
Chief fellow. All right. Why don't we start on this side of the table? We'll just go around. Maria's already given her answer. So this one's above the angular ligament.
Okay. So, yeah, external.
Perfect. That's an early eye.
Is that the common?
Yes, ma'am. Very good. Dr. Bailey.
That's the greater staff.
Yes, perfect. Perfect.
You know, saphenous just means vein. That's so lame.
It's the greater vein.
Well, like, you know, often like it can give you like a hint,
Yeah, but this is.
but it's not. It's the veiny vein.
It's the vein of, it's the vein vein.
There's a couple different saphenous veins in your leg. There's an anterior and posterior accessory saphenous.
Yeah,
So this one's the biggest. It's just the biggest vein, like.
the greater one.
Kevin
But it's still not the common. Poor naming.
For a name change, like superficial.
What's going on here? I gotta think I know it out.
Leg.
All right, all right.
Well,
Yes, sir. Femoral vein, very nice. Then this one,
that's the deep femoral.
very nice. And here,
That's the, what do we just call it? The accessory, the perforator.
yes, lateral perforator, perfect. And then, Evan, would you do the honors for the last one? Popliteal, very good. All right. So what questions do you have about what we talked about here? Maria, you cannot ask me.
I was gonna say, this was actually a great lecture. I appreciate
Oh, thank you.
it. This was very good. You did a great job.
But in all seriousness, what questions do you guys have? So this is an exam that you should be able to go, back to the unit and actually do. You'll get better at this as you do more and more of them. Certainly don't want to put patients through undue pain, but if someone's intubated and, you want to practice this exam, this is one that I think if you do 20 of them, you'll be able to catch DVTs. And I guarantee you that before your fellowship is over, is if you do this exam on patients that you have a suspicion, you're going to find a DVT. If you work with me at Espinaza, you're also going to find a pseudoaneurysm apparently. They seem to just come on my service all the time.
So do you, like, if you find one on your own bedside exam, do you get a formal, you feel comfortable enough just anticoagulating?
I personally do. Sydney and I found one in the emergency department. Clear DVT. We started anticoagulation and got a formal, and the clot was gone. But we will continue anticoagulation anyway.
Okay,
So I think if you're a fellow and you're worried about liability, I would always get a formal. But once you've done this many times, and of course we left a picture in the chart,
Sure.
figure out what we did. But yeah, I'll start it right away.
okay.
So I guess from like a practical standpoint too, is that something that like you can have in the chart and you can like bill for on this?
Yeah, so there's a code for limited DVT exam. It pays about 0.5 RVUs.
How much is that?
So RVUs around 67, about $30.
Wow.
Not that you're gonna get it.
Good luck. Yeah.
For billing purposes, absolutely.
Do you need to be certified though to go for it?
No, so the AMA came out with a statement, I think back in '96, that ultrasound can be used and billed by anyone who has the appropriate training. So right now, there's no definition of what appropriate training is. I think, certainly you all will have the appropriate training to do this and you'll be comfortable enough to do it. Back to the billing question. So CMS has certain guidelines to bill for ultrasound. At Eskenazi, we have a smart set for this. You have to put your name, the patient's name, the indication, a little bit of a summary about what you think is going on with the patient. You have to put the ultrasound exam that you did, along with the ICD-10 code, a picture, preferably a video, but all we can do at SQ right now is our pictures. Then what your interpretation of the picture was, and then what your plan is for what you've done. If you hit all those elements, you can go for the study.
$30.
I think you can do a video through Haiku.
I've never been able to. Apparently September, we're gonna get synchronicity as a division. So we should be able to do more videos when that time comes.
If you just use the little app, I did it last week,
Oh, cool. Okay.
so
Yeah, I would love to do that.
maybe it's new.
$30.
Oh my God.
Future private practice. So here are my references. If you guys see me around and you want to do this exam, just call me or we'll do it. It's pretty fast. Pretty easy.
Which ICUs are you visiting us to help us?
You guys are FD. Okay, I'll come to university too, kind of based on our schedule, and then John will be.
Well, probably also.
All right.
We've had our election, right?
Yep.
Are you gonna get one?
No, but they are gonna treat that guy.
Okay.
Oh, really?
It's been
You got a blast bill?
a fun infectious service.
Wait, is that guy? That's good now.
Yeah,
I thought you were in black though.
yeah.
Oh, but it is.
Huh?
That green all this stuff.
Oh, I'm sorry.
Do you have like
Yeah.
programs we can learn?
I like to, I will have fun. And do that, take all like, whole 3 minutes here, 1 minute here, like that's this. It's wrong.
Good.
See, Sarah, I'm gonna.
Insurance.
Yeah.
What was that, Kevin? I heard by name.
So, yeah, I'll talk